Good afternoon and welcome. I want to thank everyone for coming to the second hearing of the Select Committee on Children with Special Needs. I really appreciate the great attendance here, especially since I know there's many other committees having hearings this afternoon as well. And again, really want to thank everyone for being here and your interest in this very important population. And I also just wanted to particularly thank the Lucille Packard Foundation for the tremendous support they've been providing the Select Committee. And I see Dr. Ed Shore here, and also Christina Pena, who's also on the foundation staff, has been doing a lot of the work and helping us put this hearing together. Since establishing the Select Committee on Children with Special Needs last fall, we've been hearing from families, providers, and experts about how challenging care coordination can be for children and youth with special needs, and especially for families who have to navigate services from multiple agencies and providers. And in fact, our first hearing that we had, we sort of did an overview looking at four major systems of care that this Select Committee has been sort of digging into, and that includes sort of physical health, usually through the Medi-Cal system and CCS, mental health, again through Medi-Cal and the county mental health system, developmental disabilities through the regional centers, and education, particularly special education. And the Select Committee has started to collect information from departments, agencies, providers, and families to better understand how these systems of care are working together, or not, to provide services and care to children with special needs. And we're really looking at opportunities to improve and strengthen these systems of care. And we have heard from families and providers that these systems and many programs is often functioning in separate silos. And given the complexities of these systems of care and the wide variation of care and services available to children and youth special needs and their families between counties, the Select Committee decided to hold this hearing, the second hearing, really focused on interagency care coordination. The American Academy of Pediatrics definition for care coordination is that care coordination should be a team and family-driven process that improves family and healthcare practitioner satisfaction, facilitates children's and youth's access to services, improves care outcomes, as well as other outcomes actually, and reduces costs associated with fragmentation, which can lead to both under and overutilization of services. And so in today's hearing, we're addressing care coordination by taking a step back and really looking at how departments and agencies are working together to address and facilitate interagency care coordination. And we want to see if we can try to achieve a better understanding about how leading departments are defining interagency care coordination, the role that departments are taking and engaging in interagency care coordination. And we hope that this hearing will provide some examples as well of interagency care activities and relationships currently underway by departments and in particular areas to address care and services specifically for children with special needs. We also want to examine untapped opportunities to better fund and support these care coordination activities beyond the status quo, beyond what people are currently doing. And so we're going to be hearing from four innovative models currently addressing interagency care coordination at the county level. And while we've been looking into this issue and addressing these issues, it's clearly a major challenge that's echoed across counties at the community level. And it is surprising just how few working models we were able to find in terms of addressing this particular issue. And in fact, we spent the past several months researching models, and the truth is that models and approaches to streamline interagency care coordination are tough to find. And we know that we are working in a context of a structure where from everything from the federal level to the state level to local levels, where funding streams and regulations and laws and so forth don't always facilitate care coordination and interactions. So in fact, hopefully in terms of our agenda here for our Select Committee, this discussion will help prompt some thoughts about what are things we should do as legislators and other policymakers can do to try to break down some of those barriers so we can improve quality of care. So there are some key questions we're hoping to explore. So one is how do we define interagency care coordination and interagency care coordination, who's eligible to receive care coordination, which populations are most in need, and who provides these care coordination services and supports, and how much involvement departments and agencies should have in coordinating care and services. And we've heard from families about having to care coordinate or service coordinate the care coordinators because everyone's in different silos. So thinking about how can we make more effective use of our resources, how can we simplify things for families and their children, and how can we then lead to better outcomes and also more efficient use of both public and private resources. So with that, I want to again thank everyone for being here. We have looking forward to the discussion we're going to have in this hearing, and we're going to open up with our first presenter, who is Dr. David Bergman, who's Associate Professor at Stanford, who's going to be giving us an interview of interagency care coordination. Thank you, Dr. Bergman, and welcome.
Well, thank you for inviting me. I must admit, when I looked at my calendar this week and saw an overview of interagency care coordination in 10 minutes, I pinched myself, but I'm going to give it a good shot. I want to tell you just briefly about myself so you'll understand my biases. I come to this primarily as a provider. I co-direct a complex primary care clinic where we provide a medical home for kids who have medical complexity and as such really give them the full breadth of care. I also serve as a medical director for a large CMS contract where we're engaged with implementing a new care model in 10 children's hospitals across the country paired with new payment models in 8 states. So I have my finger to the pulse about a lot of programs and hope to be able to share some of the challenges and some of the successes of these participating programs. So I wanted to start out with a parent story. I think when I talked to some of our parent mentors, there were plenty of stories out there that are just really, really bad. But I really wanted to give you one that was typical of some of the issues that we confront day to day, at least in our clinic. So this first story concerns baby AJ. He was born 26 weeks premature. He had kind of a rocky neonatal intensive care unit course. And because of his high-risk status for developmental delays, he was appropriately referred by the hospital to the high-risk infant follow-up clinic, the regional center services, and CCS. Unfortunately, no one really talked to Mom in great detail about what any of these services were, just gave her phone numbers and told her who to call. Because of her confusion, because of the fact she was overwhelmed with this premature infant at home, she didn't really follow up on any of these services. At 6 months, however, she did go to the high-risk infant follow-up appointment, was found to be developmentally delayed with increased muscle tone. Again, the family was referred to the regional center in CCS, so they went ahead at least with the CCS referral and were told because they had a family income over $40,000 that CCS services were denied. And no one had told Mom that she was applying for therapy services only and that there was no income requirement. So she really felt that she wasn't eligible for CCS services. She did apply to the regional center and was finally able to talk to them, but it was a slow process where she didn't get a lot of feedback and a lot of explanation. And because the family had private insurance, she was told she would need to get a denial of therapy services from her insurance company before she could access services through Early Start. And still, no one at the regional center told her that she was eligible for CCS therapy services. So at 11 months of age, she was seen in our complex care clinic. She met with her parent mentor, asked for help getting her insurance company to either deny the therapy services or provide them. At that point, she hadn't really been able to get anyone to respond. Her pediatrician was reluctant to make the diagnosis of spasticity, which made it harder for the mother to get services. And really, from the mom's perspective, none of these agencies were talking to each other or to her pediatrician, and she really felt that there was no coordination of services attempted. Eventually, the mom was connected with CCS, for therapy, and she receives occupational and physical therapy twice a week, and she is also receiving early intervention in the home through the regional center. So I tell you the story that it's not an easy business for families, and it's complicated out there, and even for some of our major stakeholders in California, at least for this one family, they weren't seeing the care coordination that they'd hoped for. This is kind of an iconic care map that was developed by Kristen Lind, who's a mother of 2 children with special health care needs, who lives in Cambridge, Massachusetts, and is fairly savvy, goes to Cambridge Pediatrics, excellent pediatric program. And so at some point she decided to put down what are all the people I need to have contact with, what kind of coordination I need. And I think the diagram really speaks for itself. It's a very, very complex system. I just wanted to share with you, this was a social network analysis, again, both at the level of the parent and the child and also at the system level, about what kind of communications and information exchanges took place in the care for a child with special health care needs. And all you really need to see here again is the complexity, that in order to really manage the care for these folks, not only does the parent have to be speaking to many institutions, but these institutions need to be speaking to each other. So who are the players in regional care coordination in California, at least from my perspective? Certainly we see CCS, regional centers, county mental health centers, hospitals, pediatric subspecialty clinics, managed care organizations, home care agencies, daycare, preschool, schools. It's kind of curious, I forgot to put primary care physicians on here, but we should definitely add them to the group. I think if you look across the board, one of the big messages that came across for me, and I'll try and give it to you early in this talk, that there is really no single child-centered entity that's responsible for care coordination for kids. I really hope to be proven wrong this afternoon by hearing from some of the programs that we'll be presenting today, but from my perspective and the perspective of the 9 other hospitals I work with, we really are crying out for some single entity for care coordination. And I think Senator Pan already referred to this comment that's been made by many parents. We need a care coordinator for all our care coordinators. And we did have an episode the other day where we had 6 social workers for 1 child in the same room attempting to manage care. And as you might speculate, that none of the social workers knew each other. So this is a challenging task for families, and this is from the survey for children with special health care needs. And just to show you that over almost 14% of families are spending 11 plus hours a week on care coordination. This is above and beyond the direct patient care they have to give to their children, and that 6 to 10 hours was 6.7%. So really a lot of the care coordination we've done really has been on the backs of parents. And they really have to be able to step up and spend the time and energy to do the care coordination. That obviously has consequences, with over 50% experiencing financial problems, more than half of having a family member who needed to stop working, and 9% who needed additional income for medical expenses. So it's a considerable burden for families. So what are some of the key issues, at least as I see them in regional care coordination? The first one is who needs care coordination. This should be self-evident, but it really isn't. And trying to figure out algorithms and means and ways to identify who's eligible and who's most in need for intensive care management is a challenging task. And the second issue, what comprises good care coordination? What are the components of evidence-based care coordination? And lastly, I'll try and touch on how do you pay for care coordination? How do you align incentives for high-quality care? So let's look at this issue of who needs care coordinations. There's been a number of approaches to it. The first one, as you might imagine, is let's look at the big spenders. So this is high resource use, and these are the folks who, because of their high resource use, need intensive care coordination. We've also attempted to look at specific diagnoses or clusters of diagnoses of kids that we anticipate will need care coordination. And lastly, we've tried to begin also to look at kids with behavioral problems and kids that have issues with the social determinants of health, housing, immigration, food. and things like that. And where does that interplay on who needs care coordination? So let's jump into this with the big spenders. As you can see, this is from CCS data, and the major point is that 10% of children account for 64% of expenditures, 1% of children account for 20% of expenditures, and in other states that actually goes as high as 30%. So I figure looking at big spenders might be the way to go. It's only 1%, 20 to 30% of resource use. If we can target this 1%, then we'll save a lot of money and hopefully do a lot of good. Well, this slide I know is hard to read, but it's some work that's been done by Al Cohn, who looked at big spenders. They looked back at big spenders and say, do they persist in being big spenders? And on the bottom, you can see the percentage, which ranges here from 8% to 30%, who are big spenders over the next 3 or 4 years. So unlike the adult world, as you can target big spenders in the beginning by looking backwards at their claims data, but it's not a good prediction for what they're going to be doing in the future. So it's a starting place, but it's still not going to really begin to capture these kids. Then there's also the kids who don't spend a lot because they don't seek out the care they need. And again, we miss these kids too. So another approach has been, well, maybe we can find a set of diagnoses. And there's been a number of methodologies that have been implemented and tried. One is looking at sets of conditions, of complex chronic conditions, trying to look at kids that are neurologically impaired, trying to look at kids that are technology dependent. The major point here is that the chartreuse area is where these all overlap. And then you can see these other ovals in this Euler diagram, which show that any particular method always leaves out a significant group of others. So we really haven't found a good algorithmic solution or a good diagnose-based solution to who really needs intensive care coordination. What about issues with emotional and behavioral problems? And this was from some work that was done by Christy Bethel looking at the impact of emotional, developmental, and behavioral problems on kids who have chronic illness. And as you can see, these kids who have emotional, developmental, and behavioral problems are also big spenders. So somehow it seems that if we can target some of these kids who have these problems, that it will make a difference. Then what about the social determinants of care? We've not done a lot of research in this in the pediatric side. On the adult side, my goodness, there's been a lot of good work, and you have ACO systems out there that are building housing for their patients because they found out this is the best way to meet their needs and reduce their costs, and this is the key leverage point. This just underscores 2 studies that were done out of Seattle showing association between utilization of the emergency department and poverty, participation in the juvenile justice system, child substance abuse treatment, and then also looking at social complexity risk factors and a caregiver report for care coordination. And again, particularly if you're involved with the child welfare system, this is a strong predictor. So what we're left with is kind of a mix of causal factors here and no real magic solution for trying to identify who really needs intensive care coordination. And I think that is one of our ongoing challenges. So just again to underscore this, I think there are probably some staged methods, but I think at the bottom line, it has to be determined at a patient level. So at some point you have to actually sit down and talk to families, find out what their care coordination needs are, and then really attempt to tailor the services to meet these needs. But this is time consuming. In our 10 programs, we've been administering a care coordination survey to all our families, and it's been very illuminating. There's been a lot of needs that were identified, but it does mean that you have to engage with the family and spend the time going over the survey. So what is good care coordination? What are the key components? Well, you can see them here, and I won't read them off to you. But I will tell you, when we looked at our complex care programs at leading children's hospitals across the country, we were a little bit dismayed that for many of these kids in most of the programs, they did not have a care plan that was developed in a shared manner between parents and providers, and similarly, they didn't have patient care goals. Many situations, they had a healthcare team, but the family had no idea who it was. And and the healthcare team per se rarely communicated with each other. So these were all major things that we consider core to care coordination, but even in eminent programs around the country weren't occurring, just to underscore that this is difficult to do. So what's the evidence base of care coordination? Difficult to say. So there are a number of trials that have looked at programs that have what is labeled intensive care management, which involves care coordination, but also involves frequent touches with the family and a lot of close contact. And there's been some randomized controlled trials that, again, have showed mixed results. Some of the successful ones targeted the sickest kids who had and provided an extremely intense intervention, and they were able to show impact. Some that tend to target a broader range of kids were less impactful. A number of prospective studies out there that looked at what happened to total cost of care and resource use prior to the implementation of the program and what happened afterwards, and were able and are able to continue to demonstrate significant cost savings. And currently, as part of the CMS contract I participate in, there is a large trial underway where we're looking at the impact of our care model, of which care coordination is a big piece, on the total cost of care, and also on aspects of a patient experience. So we're beginning to get some data on that, and we should hopefully find something useful in the next year or so. What about paying for care coordination, about aligning incentives? How do we currently pay for care coordination? Well, we have salaried health professionals that exist both within provider networks, exist within health plans, and exist within some of our agencies, such as CCS and the regional center. In some areas across the country, there's a per member per month reimbursement, but usually this is calculated across all kids, and it usually doesn't come close to approximating the needs of particularly of kids with significant chronic conditions. There's the units of service, so there's various care coordination codes that you can bill for, and we do actively bill for them, but there's very few payers that pay for them. So, the bottom line from my perspective is our current system really does not adequately reimburse for care coordination services. And more importantly, I think we're not really incentivized to undertake these activities other than our sense of goodwill in doing what's best for the patients. We'd really like to see situations where if we're going to get care coordination payment, that it be quality-based. Or in some situations, I think perhaps you'll be at risk for the health of a population, and that it will, through upside or downside shared savings, that you'll accrue some benefits from being able to keep these kids healthy through care coordination. But right now, for most providers out there, there is no financial or quality incentive to provide care coordination. So to sum it up, what can we say? Is that regional care coordination is complex and it's challenging. The work is often shifted to parents. There's a need to tier children with special health care needs. Some may need next to no care coordination. Others may need to be an extreme amount of care coordination. We have to be able to identify kids. We have to be able to tier them according to their need, and we have to be able to rationally allocate the resources. We clearly don't have enough to take care of all the kids, so it's actually imperative that we identify the kids in greatest need. We need to align the incentives to reward both improved quality and cost savings when it becomes to care coordination. And ideally, there should be a single child-centered entity for care coordination. But given that they may not happen in my lifetime, at least a clear delegation and coordination of tasks among the stakeholders so we can hopefully reduce some of the redundancy and confusion. And I'd be happy to answer any questions.
Well, thank you. Thank you so very much, Dr. Bergman. Thank you so much for that wonderful presentation. I do have a few questions. So first of all, I guess you had presented that there are families that average 11 hours a week or more on care coordination for their child, and that many families, I think about over half families, actually are unable to actually work or employment because they have to spend time trying to care for their child, and including coordinating their care. And we talk about, to a certain extent, we talk about the need for care coordination. We talk about the role of the families. Should we be looking at how do we build the capacity of these parents and even pay them to do care coordination? Maybe we often talk about a model where we hire professionals to do this, and there's a certain extent that of course we will need people with professional training to help out with. And to a certain degree, we've made the system so complex that something that we need people who are master's level trained to figure this out. But also at the same time, are there, and I realize that's probably as much a question for the policymakers in terms of, but from a research perspective, there's two paths. One is like we can try to develop professional care coordinators who can, and hopefully the policymakers find a way to pay for them, or there's another route to try to, and they're not exclusive of each other, is to actually find a way to build the capacity of the parents, give them the training, and actually even give them the financial supports to do that. Any thoughts on that?
Yeah, and I think you've really hit it spot on. I think, at Packard, we have a number of self-management modules that we give families to really help them navigate the system and learn how to communicate, how to, get these financial questions answered. A lot of it is also makes it a lot easier for the families if we have identified care team for them, that we actually hear from the family who should be on their care team. We have identified access plans so they know who to contact and when to contact and how to contact them, and also that we have shared goals with the family. So then if a lot of that structure is in place, that really enables the family to do a great deal. On the other hand, there are some families that, they're working, they may not have the level of function, and they do really need some professional support. I think what's interesting, what's getting tested in a number of places, is do you necessarily need an RN or a registered nurse to be that care coordinator? Could you just as effectively have a person in the community? Could you take a medical assistant and train them up to be a care coordinator? Or in our system, we have a parent we've trained up to be a parent mentor, who probably is our most effective care coordinator. So I think both those paths are viable and important.
Do you know, is there any, you've talked about some studies people are doing looking at care coordination, and in fact, I don't know if they're just focused more on sort of medical or medical related services versus, we want to start touching on education and some other services as well. So how expansive that care coordination is that they're evaluating, but also is anyone looking at anybody doing studies on parent and actually also, so I guess two questions. One is that the scope of the studies that are looking at care coordination, and exactly how broad is that care coordination? And then the second question is sort of related to my first one in relation to is anyone actually trying to do evaluation? So is there, for example, an opportunity to, it wouldn't be the primary reason we do it, but to save money actually by building the capacity of parents? I mean, if there's financial value to that, to all of us who are paying for these services, then shouldn't some of that value, some of that monetary value of that then be passed on to the families?
Exactly. So two really great questions. I think in the first one, we often talk about vertical integration up and down the healthcare system, which a lot of hospitals are getting better at. But I think more importantly is the horizontal integration across the community, which I think people are trying to measure. But in all honesty, it's problematic to measure care coordination. What we've attempted to do in our 10-site study is to use validated instruments to get a parent's perception of care coordination and the various components of care coordination. So that gives us some reality. We've also used validated surveys to look at impact on the family, because the hope is if we can make life easier, we can improve some of the day-to-day impacts that families suffer from. So I think those are two important ways to measure and look going forward. But we're still waiting on the great studies to demonstrate this.
Okay. Well, again, thank you so very much, Dr. Bergman, for your presentation. It'd be great if we had more time, but thank you again, and I appreciate you taking your time to present to us, and hopefully we can follow up on many of the things you presented.
Thank you for having me.
Thank you. Thanks very much. Hey. So the next item on our agenda, unfortunately, we were planning to have a family from Family Voices come, but unfortunately, she's dealing with some family challenges, and so was not able to make it here. So I did want to just note that, and So we won't be having Ms. King, who's with Family Voices, who's going to share her own personal experiences, because unfortunately she's going through a personal experience at the moment and is unable to be here. So we're going to go ahead and move forward with the presentation of the 4 models in here in California. So first we're going to start with is the next panel is committees and pilot coalition models currently underway in California address interagency care coordination, and we have both Alameda County Special Needs Committee. We have Lori Soman, the committee coordinator, and then we also have we have another pilot, Alameda County CCS Mental Health Stakeholder Coalition. And I understand we have Barbara Sheehy, Mental Health Initiative Coordinator, and Ellen Muir, the Assistant Director of EPDSDT. So if you can please come up, and I want to thank you so much for being here and sharing what you've learned from your experiences and your observations in doing this work on the front lines. Thank you. So we'll start with Ms. Soman with the Special Needs Committee.
Thank you.
I think we're pulling up the slides too.
And there it is, all teed up. Good afternoon, Senator Pan. I'm Laurie Soman. I'm Senior Policy Analyst with Lucille Packard Children's Hospital. And as you can see, I've been asked to talk about the Alameda County Committee on Children with Special Needs, which I convene. And I've been asked to do 3 things: provide a brief overview of the committee, discuss some of the committee's successes in strengthening coordination among key agencies and services in our community, and then do a little bit of addressing the systems barriers that challenge our committee and other communities as we try to approach systems coordination. So let's test the clicker. There we go. Great. So, in terms of an overview, we were established in 1993, which is fairly frightening that we've been around for 23 years, as a county-wide multidisciplinary group. And originally, we were created to assist Alameda County as it was working to plan to create and implement its Medi-Cal managed care plan. And we were particularly interested with what was potentially going to happen to children with special needs as broadly defined in Medi-Cal managed care, and obviously much has happened over the last 20-plus years. So we began with an emphasis on children and youth with special needs as very broadly defined. So that would include children with CCS conditions, children in foster care, children with behavioral or mental health conditions, children with developmental disabilities. But our goal was always explicitly to promote access to health care for vulnerable children via interagency coordination, which we were looking at as systems-level coordination. So we don't engage in discussing individual cases. So I think that's a really important distinction to make about what we do. Next. Okay, so as you can see, it's pretty multidisciplinary and countywide. Sorry, it would be much happier if there were 2 screens, but so we have a membership that includes what I'd call the major county child health programs: CHDP, Child Health and Disability Prevention, CCS, Family Resource Navigators, which is our local family resource center for children with special needs and their families, First 5 Alameda County, community and hospital-based pediatricians from both Packard and UCSF Benioff Children's Hospital, Oakland. We include the health plans, because obviously we've always had a strong relationship with the Alameda Alliance for Health, our regional center for children with and adults with developmental disabilities. Kaiser is involved, special education. So I think it meets most of the criteria that Dr. Bergman laid out. And then we bring in additional partners when we need them. So as you'll hear a little bit about, we brought in Beacon Health Strategies in particular, which is the group that the Alameda Alliance is contracting with to carry out its mandate to be responsible for mild to moderate mental health services and for services for children with autism. And we've recently, after a long hiatus, brought Anthem Blue Cross back in. And we're also funded through a partnership with Packard Children's Hospital, First 5 Alameda County, and Alameda County Public Health. So even in our funding, I think we're modeling interagency coordination and collaboration. So in terms of committee activities, clearly focusing on systems issues affecting children and youth with special needs. As you've seen by our list of members, we convene multiple partners to identify these problems and to try to develop feasible solutions that hopefully we can have some hand in implementing. We also do something else that's sort of very particular, but I'm proud of it. We have a particular interest in developing information and resources to do with services and service systems for pediatric providers to help them better serve children and families. And the committee had created a medical home project many years ago, which is still in existence, and it's that arm of the committee that carries out that very particular work of working directly, again, not with the families or the children, but with the providers to make sure they understand what the systems are, how they work, the various changes we've seen, particularly over the last decade, and how they can work those systems for their patients. So our current issues that I'm going to talk about a little bit are three. The first is the one I mentioned about the recent transfer to Medi-Cal managed care plans of responsibility for mild to moderate mental health services. Okay. The second is a similar transfer to Medi-Cal managed care plans of responsibility for services for people with autism or people on the spectrum. And then the third is this concept of better integration of pediatric primary care and mental health services. So if we look at the first one of Medi-Cal managed care plan responsibility for both mild to moderate mental health and autism services, this is where we've been working very deliberately and consciously with the Alameda Alliance and with its contractor, Beacon, who is actually responsible for constructing the networks and for receiving referrals and ensuring that families are linked up with services for their children. So we've been working directly with the Alliance and Beacon, and more recently, as I said, we've brought Anthem Blue Cross in to work with them. And this is, again, all about systems-level work, but improving access for individual children and families to those services through the system-level work. Some of the successes are during this work with the Alliance and Beacon, we managed to get them to accept a number of recommendations, including organizing training webinars specifically for primary care providers on what these new benefits are, what the referral process is, and how families can actually access them. And what's worth considering here is that even though Beacon had prepared a number of materials, it hadn't occurred to them they should be considering training. That wasn't so because we have primary care pediatricians and others at the table, they were able to say, oh, you really have to reach out to us with some more concrete training for us to really understand how these materials translate to an actual system for our kids to get care. So that's the first thing. And second is just something as simple as making changes to both the referral forms and the family consent forms so they're workable. For example, the family consent was in English only, right? So not something that had occurred to Beacon as a problem, but obviously our providers and family organizations looked at it and said, at minimum, it has to be in Spanish as well. And that's something they're willing to do to make those kinds of changes. And then another activity we're engaging in now is we developed a report form to capture information on barriers to access to both mild to moderate mental health services and autism-related services for the providers. And the idea is for them to give us enough information so we know where the problem was located, what seems to be the cause of it, as far as they can determine what steps they might have taken to try and resolve it. And then we are aggregating that information and taking it directly to the Alliance, to Beacon Health Strategies, and to Blue Cross, and working through what can we do to make changes so that actually works, so we can solve the barriers. But we didn't feel that we could adequately convey that to the plans or their subcontractor without having a sense from the providers of where are they seeing those problems. And Family Resource Navigators, our family resource organization in Alameda County, is looking at taking that form and turning it into a family-friendly form and collecting the same information at the family level. And this is actually something we did many, many years ago around the implementation of Medi-Cal managed care, where we used a similar kind of form to collect that information. And then we were able to take that right back directly, particularly to the Alameda Alliance, and say, here's what our folks are saying they're experiencing as barriers. And we're able to work with them on how you can fix that. So again, systems level integration, all aimed at identifying problems and hopefully solving them. So next issue is improved integration of pediatric primary and behavioral health care. And this is one where we know that there are systems barriers to direct communication between children's primary care providers and particularly their EPSDT mental health providers. And some of this is HIPAA related, some of it is, which is the Federal Privacy Protection Act, and some of it is related to stronger federal regulations that are aimed at protecting mental health information, and we respect that. But we think sometimes as maybe a misinterpretation of some of HIPAA and federal regulation that there have been barriers to that kind of communication, and we've actually seen situations where, for example, primary care providers may be unaware of medications that have been prescribed, right, on the psychiatric side. So there are things like that we had identified, and we knew that this is kind of poor coordination actually could cause lots of problems, not only for the kids medically, but kind of breakdown in communication with families. This is not the way we wanted to do business. So in this case, the Alameda County Committee put together a multidisciplinary subcommittee, so a subset. And one of the people who's on it is Ellen Muir, sitting right here from County Behavioral Health. It has primary care providers. It has some of the EPSDT mental health providers who are contracted with the county. And again, stressing families are at the table there to really work through what's not working here, where is there miscommunication, where are there just cultural differences in how the medical world looks at something and how the psychological world, therapeutic world looks at it. And some of the activities that we've created so far are an online toolkit for providers. We organized a little over a year ago a countywide training, bringing together primary care providers and the mental health providers with family representation, talking about their experience. We're working on county mental health provider contract language that could require better coordination with primary care providers. And Ellen Muir, most amazingly, is looking at the possibility for potential county payment for PCP mental health provider coordination, which is quite amazing and not something that and I think Dr. Bergman touched on that as a major barrier when care coordination is not paid for. So those are successes, but I've also been asked to talk just a second about systems barriers to care coordination. And this is going to sound very familiar to what Dr. Bergman was talking about. So a major one is just this division of child-focused services and agencies in separate silos at both the state and the local level. So we have different programs for different conditions, like medical, developmental, psychological, and there are differing program eligibility criteria that don't match up, and that's by things like age, by income, by condition. The programs outside of our county, I think we're doing pretty well in the play well together arena, but we do know that programs don't always play well together. And as Dr. Bergman spoke quite eloquently about, there are very few incentives for programs to coordinate, and sometimes there are active disincentives. And then also, I think, as he mentioned, there are few local vehicles for systems level coordination. There just aren't that many, and I think that's why you've got the folks you have here today speaking on these panels. And part of that is because they have to be stable, and I think we qualify after 23 years. I think that we meet the stable criterion. But you have to be stable to attract long-term membership and build trust. So people at our meetings, I think, we don't always agree. But I think I feel pretty confident in saying that we can tackle some difficult subjects because people have been at the table long enough that they trust how information is going to be used, and that this is not about attacking or blaming or storing up points to use later, that this is really about how can we work together to make the systems work better for kids and families. And one other thing I'll put in there is I think part of the stability is requiring at least minimal paid staff to support activities. We've had that, and we haven't had it. And I'll tell you, it's much better when you do have it, that you can accomplish a lot more, and you can be assured that you can keep this kind of coordination body going when there's at least some administrative support, not only to convene the meetings themselves, that's the easy part, but to really follow through on projects and activities that are actually the things that really are going to make the difference in kids' lives. So, I guess in conclusion, I would say I think it's clear that systems coordination has to be promoted at all the system levels. We need to see it better at the state. And we have some good examples of where that has happened at the state, and we clearly have examples locally, but I think it's more the exception rather than the norm. I'd stress they have to be multidisciplinary, which obviously Dr. Bergman talked about. And the special stress for me here, and I'm really sorry that Kashaw couldn't be here to talk to you because she does such a wonderful job of talking about it, but it's so critically important to have families of these kids as part of the process. Even providers who work directly with the families are not living the family experience. So they absolutely have to be part of this. And then to repeat, these kinds of bodies have to be stable and long-term. They have to build trusting relationships, and I really feel that that requires some kind of paid staff support. And I'll close there. Welcome questions, and thank you so much for having me speak.
Hey, thank you. So we'll move on with the panel. We'll do the questions at the end. So again, welcome. Thank you.
And
Great.
I don't know, are you setting that up? Christina?
I'm Barbara Sheehy, and I'm the project coordinator for the Alameda County, California Children's Services Mental Health Initiative. And Ellen Muir, one of our primary partners on the collaborative, is with Alameda County Behavioral Health Care Services. As far as our initiative goals and objectives, we set out to organize the coalition, so bringing together stakeholders from most of the child and youth serving agencies in Alameda County. And we really were able to benefit from the foundation that the Special Needs Committee that Lori just described has that long history in Alameda County. So I think it made it easier for us to actually pull together stakeholders to zero in on a particular area of focus. And what we wished to address was improving access to mental health services for CCS clients and potentially their families. And lastly, we wanted to look at improving participation of mental health providers in serving our CCS clients and families. And in 2014, Alameda County CCS decided to focus on this particular care coordination need. And rather anecdotally, they learned from their family advisory committee, which Alameda County CCS has, and from their own experience within the CCS program and community members, that mental health needs, particularly related to a child's CCS medical condition, were oftentimes not being addressed. It wasn't really heavily on people's radar, nor for parents of the kids. And because the Lucille Packard Foundation for Children's Health was providing grants to start care coordination projects, Alameda County CCS applied for such a grant. And we not only benefit from the foundation in getting technical assistance with our local work, but there's also a learning collaborative that they host with the other grantees. So we learn from one another about establishing and trying to maintain these local collaboratives. So in terms of the structure and the stakeholder participation, we have our usual membership at our monthly meetings is 25 stakeholders thereabouts. And like the Special Needs Committee, we have really good representation from our local Family Resource Navigator agency, as well as some specific family members from CCS who come and tell their particular stories. We also have some mental health providers who focus specifically. One agency focuses on people with disabilities, another specifically serves people with deafness and who are hard of hearing. Then in addition, the Child Health and Disability Prevention Agency, Alameda County Behavioral Health Care Services, the Regional Center, UCSF Benioff Children's Hospital, one of our 5 SELPAs in the county, the Developmental Disabilities Council from Alameda County, First 5, and more. And the way we've been meeting now for a year. Our project ends in June. And in addition to the large stakeholder meetings that are held monthly, then we have an internal executive committee and an advisory committee to kind of steer the work and get a lot of work done in between those monthly meetings. What we found is about 6 months into our project, we did a stakeholder survey to really assess whether our project and the meetings were having an impact. And the stakeholders reported that they either agreed or strongly agreed that our collaborative did provide a place to really highlight the mental health issues and service access related to CCS clients and their families. It really sort of raised people's awareness of the CCS program, the very diverse needs of children within that program and their families. It gave us an opportunity to work collaboratively together to learn about the mental health services available and how referral pathways were working or not. And then also just gave us a chance to sort of jointly advocate on behalf of this population. We're going to be doing a second survey later this month to both look again at how the project has served the collaborative and the community, and also to get input on a focus for a next phase of the project. And I'm going to hand it over to Ellen from there.
Okay, great. Thank you very much. Appreciate that. Hi, I'm Ellen Muir, and I'm the Assistant Director for Alameda County Children's System of Care. And I'll put this a little closer here so that I can hear myself too. So, let's see here.
I think it's this one on the right.
Okay, thank you. So I was asked to talk about the service system issues and the recommendations. And the first thing I want to say is we need to assume, I've worked in behavioral health care services for over 25 years, and we need to assume that California Children's Services clients and families need mental health support. It's very stressful. Whoops, hello. Are we coming back? I will just go along. Okay, and then it'll catch up with us. In Alameda County, there's 6,700 qualified California Children's Services clients, and in the state of California, I've been told that there's 180,000 CCS clients. So if you use the Substance Abuse Mental Health Services Administration data that 1 in 5 children may have be at risk for a mental health issue or disorder. In Alameda County, we should be serving about 340 kids, or 9,000 statewide. And for the CCS populations, the estimates are much, much higher as far as need. As high as 50% that mental health supports are needed due to the additional challenges of being in and out of the hospital, frequent unremitting medical diagnoses and appointments, daily health routines, family stress, and added to the fact that, and this is something I feel very strongly about, that regardless of the health diagnosis of the youth or the child, whether or not it be AIDS, cancer, a spinal cord injury, diabetes, or many of the other qualifying diagnoses, that children and youth have the same developmental desires, needs, and wishes, and the parents have the same desires for their children. So they would like to have friends, drive a car, succeed in school, not necessarily in this order, become independent, and move on and maybe go to be college and career ready. So how can we help them do that and help them deal with some of this stress? We need to also include the voice of family in the development of services. And we can learn a whole lot. I worked in behavioral health, as I said, for quite a while, and through the Mental Health Services Act, we really have engaged the consumer and peer movement, and they have a saying that goes, "Nothing about us without us." And I think that we can adopt the same saying or model or borrow from them. Our families, too, need to be involved in voice. They know what they need. We just have to ask them what they need. We also need to provide navigational support and advocacy as needed, and I think some of that's done at the system level through some of the project that Lori is working on, but also just bringing people together through our family resource navigators to help navigate those services. And then we also need to align mental health and physical health around the value of addressing the whole child and their family as a system, not just their medical condition. So when you see children or adults with a medical condition, we tend to see them as their medical condition. We don't see them as the whole person. Just recently, somebody sent me a copy of the MACPAC, the 2016 MACPAC report to Congress, which is the Medicaid and Child Health Insurance Program Access Commission report. And not surprisingly, care coordination and integrated services produce better outcomes and can be more cost effective for the families and children we serve. We also need to take a look at right now what we're doing. This is a great opportunity for us to share what we're doing locally and also look at what we can do, what is happening statewide. For example, in Orange County, Barbara and I were on a phone call with the Children's Hospital of Orange County, and their mental health plan is funding them to do a pilot project working with children who are enrolled in the local epilepsy program and provide mental health screening and services as needed. We can also train the existing provider workforce to be knowledgeable about the complex medical conditions, the impact on the family, the children, and their mental health needs. And so training providers, we did a survey in February, and we surveyed 40 of we have mostly community-based providers in our network, and there was a lack of training and experience of their staff that directly serve their children to work with children and youth with complex medical needs. But there was a desire and a will to learn more, and they're very interested in upcoming trainings that we're planning. So this is a workforce, again, back to some of the lessons learned from Mental Health Services Act. This is a workforce development issue, workforce employment and training issue. We used to hold I've been around for a long time. We used to hold multidisciplinary teams between social services, mental health, the district attorney's office, and other systems. And maybe going back to an MDT model that we once was very successful in working with particularly challenging families. I don't want to call them cases. These are people that need services. And then where we can get together, the respiratory therapist, the pediatrician, the mental health therapist, etc. Our providers in graduate school, nobody ever mentioned care coordination to me, and albeit a long time ago, even the people I know that are graduating today don't know anything about care coordination. They don't know anything about it's almost like the other side of an aisle in a wedding. You know, you have the bride side and the groom side. Well, we have the behavioral health side and the physical care side, and they seldom get together and talk. And then also quality. We should approach care coordination as and with children with medical complexity as a measure of quality services for our system. Some of the system's barriers are lack of service coordination, direction, and leadership at the state level. So although behavioral health care services, substance use disorders, and health are now under all one department, and so is the California Children's Services, we don't have strong models of or messages to work together. Or incentives. We can look to other states like the state of Massachusetts, which is an excellent model in care coordination, and there's also some great projects in Oregon where they're actually providing family therapy to children with complex medical needs, and it reduces their primary care hospitalization. We also need to look at the mental health plans and providers do not have expertise serving children. I talked about this earlier, and youth with medical complexity in their silos. Again, it's the silos of training. It's the silos that we've grown up to, so it's time to break down some of those silos. The California Children's Services Program staff are largely nurses, respiratory therapists, social workers. They may not be trained in mental health issues, so they can be trained to educate, identify, and intervene with mental health needs. And refer on when things are more complex. And then the differing agencies serve. Lori mentioned the mild to moderate to severe. In our county, we put a complex medical condition as one of the reasons you can get into our moderate to severe programs that the county serves. Instead of, so not everybody qualifies, but it's a way to say these are pretty complex kids, and just as complex as being in foster care, just as complex as being in the criminal justice system, just as complex of having psychiatric hospitalization. And then the different, like I said, the different agencies, we're a three-plan county in Alameda County, and we have separate entities, again, as Lori mentioned, for physical health and behavioral health. Poor outreach and education to clients and the families. It's kind of a social justice issue that we don't inform our families of the, what's normal child development, when there's an issue, how to access services, and what's available to address them. And then finally, we need to, again, I'm going to go back to the silo, is we need to break down some of our silos. And the silos are oftentimes driven by reimbursement programs. And as Lori said, one of the things that we're doing in Alameda County is through our mental health services, that is totally legal and eligible, collaboration is a billable mental health code. And so we are actually, I like to rename codes, but we are like adjusting one of the codes to give a new code. It's called collateral healthcare provider. So our our behavioral health people will start being able to see, and as we educate them, that they can claim for having a contact with with their primary care providers. Thank you.
Right. No, thank you very much. I apologize.
I know.
To keep staying on time here. So a couple of questions. So I understand both the coalitions and it sounds like you obviously work closely together as well. Are looking at sort of these systems level changes. Have you been able to collect any data on, well, basically for the families who are of these children, that how's life changed for them? I guess so. Obviously the system changes make a difference, but is there, because I've heard about surveys of stakeholders, but I wasn't sure we actually, and you have a family member on the console, but
Well,
in terms of
that's a good question.
what's happening on the ground, and also where are the places that you're running into a situation where, well, it'd be great if we could do that, but the state law says, or the state agency won't let us, or something of that nature.
Well, I think the billable code issue is one that people have, and that's coming up in other areas of CCS, and actually throughout Medi-Cal, care coordination code is not turned on.
For the primary care side.
On the primary care side. So I think Ellen's looking at a very creative way of getting around that, but in order to make that, have that translate to other areas, we'd need a more standardization of the ability to do that, which I don't think we have.
And we haven't even looked at how much payment you get if you could pay a bill, right?
Yeah, have you thought about what the charge will actually be?
Yeah, I know
people can go
exactly.
for?
Well, I don't want to go on record, but I know exactly how much it would be. But as far as extra care, I think that is the bottom line is that I don't know that we're thinking about providing a lot more services. It's leveraging what we are doing in a more thoughtful way. And so it's one thing to be able to pay the behavioral health providers for them contacting the primary care physician or the specialty mental health or the nurse. However, if we can't pay the primary care folks for their time as well, which is problematic right now for care coordination, or for them to be able to have telephonic conversations. So we need to think really creatively about providing mental health consultation, primary care consultation, and how could we incentivize that across our system. The information sharing, I just want to say there's another thing too. It's an information sharing piece too. You asked about that. And it's how you match who's being seen in one system and who's being seen in the other system to see whether or not you're crossing over and they're being seen in both systems. A lot of what we know is anecdotal. We were able to match some data from our medical therapy program because we have really, really sharp data people in our department, but we don't know who else we're serving of the 6,700. We know we're serving 120 youth and their families.
Yeah, I think anecdotal is the key word here. No, we don't have good data. Not to say that we couldn't figure out some creative way to collect it, but again, that's a resource issue. We'd have to think about that. So sometimes we're sort of triangulating from a bunch of different sources at one time, but most of it is anecdotal. I mean, our Family Resource Navigators that participates in the Alameda County Committee as well as on the CCS Mental Health Initiative, we get reports back of what their phone calls are looking like, right? What they're starting to hear from families or not hearing from families. Also, and this is a little bit off topic, but I'll just throw it into the mix, Alameda County is one of those with a Help Me Grow project for the 0 to 5 kids. The Medical Home Project participates in that. Again, everybody plays very nicely in Alameda County. And they've done some surveys of families as a result of their family navigation done through the family resource navigators, and they're showing incredible satisfaction on the part of the families. Now, does satisfaction also translate to better outcomes for the kids? We don't know that. So there are bits and pieces of data, but we don't really have a full picture.
Well, thank you so very much for your presentations, and this has been very helpful. And again, appreciate that. It's been around for what, 23 years, you said?
23 years.
23
It's kinda
years.
scary.
Well, that's great.
Thank
And so again, thank you so very much for
Thank you.
being here and your testimony. Thank you. Okay. Okay, so next up we have we also have the Kern County Medically Vulnerable Care Coordination Project, and good to see you, Mr. Thibault here. And we also have the Desert Mountain Children's Center contracted partnership between Desert Mountain Special Education Local Plan Area, SELPA, and the San Bernardino County Behavioral Health Department. And so we have Michael Schertel, who's Deputy Director of Children's and Recovery Support Services, San Bernardino County, Linda Lamas, Program Manager, and Jean Holtz, CEO of DMCC. So, so we have 10 minutes for each program. So I know the three of you got 10 minutes between the three, and Mark, I guess you got 10 minutes. So, and I realize it's a brief amount of time, but again, thank you all for being here and sharing your experiences as well. So, Mr. Thibault, thank you.
Thank you, Dr. Pan. I'm here representing Kern County, and I really like the flow that this session has taken. I'm going to address the issues around silos, the spider web of services, the complexity of eligibility criteria, insurance coverage, and access to care. The Medically Vulnerable Care Coordination Project, and I'll refer to it as the MVCCP, takes an ecological approach to system-wide care coordination. So we're operating at the highest level, working with our partners. We're a public-private partnership, so it's a flat organization. And I think what's important about that is that there's no one in charge of this conversation, which makes it very compatible with where people are. If you ask somebody a question and you know, looking around the room, that a lot of other people didn't want to ask the question to show their ignorance, all of a sudden they're relieved because it's been asked. And that really helps to break down barriers. We've been doing this since 2008. We have over 40 partner organizations that we work with. And our mission is to use enhanced coordination of existing case management services to measurably improve long-term outcomes for children 0 to 5. So we started off right at the beginning as a result of a parent request to look at children in that age range. And they're at risk of a lot of long-term needs. Oh, sorry. That's all right. There we are. That's our background and our mission. We receive funds from a variety of different sources. First Five Kern is a large reason for our existence. We started out of a commission meeting, and I think we need to remember that the importance of that. Our managed care providers, HealthNet and Kern Health Systems, are big supporters of us. Kaiser Permanente has supported us from the beginning. Lucille Packard Foundation for Children's Health, and San Joaquin Community Hospital. I'm reading them to you because I think that ground level community support is really important to make an impact at the system level. We're involved in a lot of other efforts, and most recently we're identified as a promising practice by the National Association of Maternal and Child Health Programs. Our partners are many. I'm not going to read this list, but it includes, with some of your other presenters, most of the key partners that need to be at the table when looking across a county and at a system level. So all of our birth hospitals are involved. Our two primary special care centers, Valley Children's and Mattel Children's Hospital of UCLA. All of our insurers, including California Children's Services, a very strong supporter. All of our Kern County departments, they're our safety net agencies, and they're an important component in working with families who they themselves may have issues, they themselves could be at risk. Our Medicaid population of births is 60%. Our poverty level is 23%, and 30% of children or more are living in poverty. So it's important to have that safety net helping all of these families. Our regional center, our school districts are an important component because that's where the children will be going. And they've recorded great results of the first 5 programs, helping their children be ready. And so to intertwine ourselves with First 5 is a very important part of this. Our clinics see most of these families, and so our big partners, our family resource centers, our parent education programs, many local agencies, as well as regional partners. You've heard mention of the California Community Care Coordination Collaborative that the Lucille Packard Foundation has sponsored since 2011. And they staff it very well. Well, that's developed into a 10 collaborative organization with 12 counties participating, and it's growing. Kern is one of the original members of that. In fact, we helped train 3 other counties in care coordination. So what's our methodology? We focus on the system serving premature infants, and 11% of our, in 2013, 11% of our 14,000 annual births are preemies. And so their families and providers are faced with a lot of challenges. And I mentioned providers. This is not just about the children, not just about the families. It's also about the providers who are seeing them, pediatricians and others. We have project staff, that was mentioned earlier, to manage meeting, and we also have an annual conference. So those opportunities provide a predictable place for people to come, to send new staff, to learn how to work together through some of these issues. Because with complex cases, they spend 80% of their time on 20% of their cases, not surprisingly. We are able to leverage funds, public and private funds, to sustain a full-time public health nurse, an RN, as our system-level care coordinator who receives referrals primarily from the NICUs in town. And we have received over 900 referrals since 2011. We do use a central database at the Public Health Department to capture this information and to do our annual retrospective study. That's a critical element in this to demonstrate value. We do have an evaluation protocol that we implement through First 5, which is, again, a very important and a big cost-saving component to documenting care coordination. So what are the key components of the process? We did not create a new organization. We support local case management services that already exist. It's a collaborative. So we went to the players who were there, and we developed with them a one-page referral acuity form that helps them quickly identify and refer cases to make sure that they're treated as early as possible. And a lot of this is based on the intuition and the contact that nurses and social workers in our NICUs have with parents, wondering, do they have the health literacy, the wherewithal to handle this complex case when they leave the hospital? That'll usually generate our philosophy of refer across the board, because there are a lot of misconceptions about what eligibility criteria exists, so it's best to refer to everybody and find out later. We focus on maintaining health insurance and a medical home and reducing preventable ER visits and hospitalizations, and I'll talk about that in a moment. Our idea is to build a strong, long-term provider partnership that is practical, affordable, and responsive to changing conditions. When I mentioned affordable, our budget for our collaborative, our incoming dollars are $100,000. And we've been meeting every year for 8 years. We meet twice a month, and you think, well, we should have solved these problems by now. We have an outbreak of congenital syphilis going on right now. That's an example, and it's not just going on in Kern County, it's actually spreading across the country. How do you deal with that within one agency? It has to be a community approach. Having these regular meetings and opportunities to bring up what's breaking news really helps get a handle on things quickly and use those relationships to their best effect. We do use longitudinal data to document our results, and we conduct cost-benefit analyses with Cal State Bakersfield to document our results as well. This has led to a transformative role of county-wide care coordination. It went from the new normal in 2008 during the recession to the normal and expected now. We just had mental health present earlier, folks from Alameda County. We now have a care coordination unit in Kern County Mental Health for the adults there. So the concept is not new, but it is useful for others to implement. So relationships, understanding about who the people are, to know people, to be able to pick up the phone when you have a difficult case makes the hugest difference in terms of solving problems. Not only learning eligibility criteria, but also how can we expedite this case. Our folks meet together on their own because they're case managers. So they've been doing this. Now they do it more frequently and with much more effect. And that's led to a lot of changes for the positive in our overall system of care. I want to share with you two examples of the transformative role of system-level, county-wide care coordination. The first is we're training staff. You heard earlier from Barbara that or it might have been Lori, that people are coming in and not being trained in care coordination. Well, what we're trying to do is encourage that. And so, for example, in 2015 at our annual conference, we held it at Cal State Bakersfield and invited the nursing students and social work students to participate. So we had 25 students. And our goal is each year to have them learn what the basics of care coordination are and how best to implement that. The best part of this story is that we've been able to, through the work of our partners, the outreach and collaboration, to have 3 special care hospitals, Valley, Mattel Children's Hospital of UCLA and Children's Hospital of Los Angeles, have either opened new clinics or building new clinics in Bakersfield. This mitigates the 2-hour drive that families were having to do sometimes 2 and 3 times a week. And so the message is, let's work together, let's reduce those missed appointments. It's a real win-win situation. I was also asked, what are some of the biggest challenges? Well, financial are one. In a county, for example, Kern relies a lot on oil revenues. They've had to implement a 2% cut in the budgets in this last year and a half or so. That's impacted all across our safety net agencies where staff are not as available as they used to be or they've had to hold positions. But we're also seeing a huge decline in first $5 that's been progressive over the last 15 years. And in 2020, we expect that to reduce our available budget by $2 million. Well, that being the case, our community partners are really going to be impacted in that regard. So we need to bolster that. What agencies or groups could you use help from to better evaluate coordination? We need more hospital ER data so that we can track the outcomes. Our annual retrospective study takes 25 cases from each of the last 3 years and looks at preventable ER visits and hospitalizations. And we're far below the national average with our population, with this special needs population. And I truly believe it's because of the extra effort that people take, and especially when they're identified to them, because a lot of these kids fall in the cracks because they're not quite severe enough and not easy enough. And lastly, I would say to improve the system, we need to empower parents, and we should have technology that's done that. Let's give them a smartphone, maps, appointments. They can work that. Thank you.
Thank you so very much. And so next, so we got 10 minutes for the 3 of you together. So Mr. Tertel, Ms. Lemus, and Ms. Holtz, welcome.
Yes.
Thank you.
Thank you.
Thank you. Okay, so my name is Linda Yamas, and I am the director of Desert Mountain Children's Center, and I'm along with my boss, Janae Holtz, who is the CEO of CA Help, which stands for the California Association of Health and Education Linked Professions. And so to put this into context where DMCC is, Desert Mountain Children's Center, we are under the administrative unit of the San Bernardino County Superintendent of Schools. Right underneath that is CA HELP, California Association of Health Education Linked Professionals, and then under that has 3 branches. One of them is Desert Mountain Children's Center, and it goes Desert Mountain SELPA, and then Desert Mountain Charter SELPA. So that's just to put all of that into context. We are located in Apple Valley County, California, and our SELPA and Desert Mountain Children's Center covers approximately 20,627 square miles, and we are in over 200 schools with 15 school districts, and all of our counselors are pretty much in each school district in that area. Geographically, we are the largest SELPA in the state, and we also include 20 LEA charter schools in that SELPA, and we provide the mental health support for all of those charter schools as well. DMCC's mission statement is the relentless pursuit of whatever works in the life of a child, and with that thinking, we often think outside the box in terms of how to get more funding and how to collaborate more for our kids to serve more kids annually. So to give a little bit of history about our agency, in 1992, the Desert Mountain SELPA hired 2 therapists to provide mental health services to children receiving special education services, and these services were provided through a fee-for-service model. That main office was in Apple Valley and still continues to be in Apple Valley. In 2003, the Desert Mountain Children's Center was awarded the Early Periodic Screening, Diagnosis, and Treatment, short for EPSDT, contract with the Department of Behavioral Health for children birth through 21 years of age. And this was primarily school-based, but as it evolved, we went into the schools, we went into the homes, we went into the community to provide mental health services. At that time, we began serving 580 students through primarily school-based services, and that was both Medi-Cal eligible kids and kids with special education services. Now, fast forward to 2016, we have multiple contracts with the San Bernardino Department of Behavioral Health, providing a continuum of care from least severe to most severe, and that's what our slide shows as all of our programs in terms of the age population and the programs associated with those ages. Now we have served from July 1st of 2015 to current almost 10,000 children because of the allowance of those contracts to be executed in the way they have been. We've also now added an office in Big Bear and in Yucca Valley, which are very underserved populations as well. And we still also have those 2 original therapists who work with us providing services, which is something we are very proud of. We have multiple funding sources in addition to our contracts with San Bernardino County Behavioral Health. But DMCC provides a portion of the match to draw down those EPSDT dollars so we can continue to work collaboratively together. And we can do that because we have pure state funding through education. So the Department of Behavioral Health has really encouraged collaborations with other community-based organizations. And so with that, we do that through releases of information that we automatically get with every assessment for our collaborative partners. So we have the ability to make care coordination happen and continue to coordinate care as we go along through treatment. Some of those collaborative partners are Child and Family Services, First 5, Department of Behavioral Health, Public Health, and our school districts as well. So we could collaborate fully at every level of treatment. We also accept some private insurance, but certainly that is not our biggest funding source. Our biggest funding source is EPSDT dollars and our AB 114 dollars. So with that history, we have worked well with our Department of Behavioral Health. If it weren't for them, we wouldn't be able to serve as many children as we do and hire more therapists and allow the care coordination that we do. Through our Medi-Cal dollars, we are able to bill intensive coordination services, and they have allowed us to do that through specific programs that we have, and we do that through a collaboration of our mental health clinician as well as a support staff who makes those appointments for our children and their families to be involved in their care coordinating and what they need. So in those meetings, we discuss the strengths and the needs of the child and the family. And we especially focus on children in foster care who have been removed from homes multiple times, so that we create stability for those children in their homes, and we provide the continuous care that they need for their mental health services as well.
So I'm going to talk a little bit about some of your questions, and the first questions having to do with obstacles and barriers. This has grown incrementally for many years. I've started really working with Desert Mountain SELPA back in 1990 when Ron Powell, who was the founding SELPA director for this agency, and I were working doing assessments for AB 3632 children. Over the course of time, what really occurred was an understanding of each other's cultures. One of the difficulties working for mental health and working with schools is the cultural differences. We speak a different language, we have different sets of goals, different expectations. I think AB 3632 was a challenge to that, but it also allowed for those who were really committed to it to be successful. And I think that's really where the foundation for our relationship developed, was very early on in the AB 3632 world. Ron Powell was particularly, I think, visionary about what could be done in relationship with behavioral health. And well before AB 3632 crashed and burned in 2011, he was already expanding what was available by competing for contracts, as well as by his willingness to promote the local share of cost. I think our first really challenging program was the SART, which is our 0 to 5 program. We were one of the first counties that decided you could use EPSDT to work for children who were under the age of 5. There were certainly a lot of complexities, and certainly our first audit was a challenge to get through and survive. But we have been a model, and certainly Desert Mountain's model for SART is well duplicated and replicated throughout the state. But that's kind of foundational. Outside of the EPSDT, they also have contracts using Mental Health Service Act. The goal is to be able to catch early on and do prevention work. So you'll notice the EIIS and the SAP. The SAT programs are largely funded through the Mental Health Service Act. This gives a range or a continuum of care, and that's another barrier that the schools face. If you just do EPSDT contracts, then you're sort of caught up in this high-end service delivery, which actually dovetails already with the special education. Doing the other Mental Health Service Act programs allows for a broader continuum, and really the objective is to catch the kids as early as possible. The 0 to 5 allows you to really address those issues that are responsible for 3 to 5-year-olds in an IEP, but actually you can do it through service delivery through SART without having to do an IEP on the cases. So most of the barriers and the objectives have really been technical. We've been able to work those out primarily because there's a willingness to trust one another and to stay with it through the complexities. Very often when I talk with schools or other agencies, sometimes CDSS, there's a sense that many of the complexities are simply obstacles we're putting in the way because we don't really want to do that. But the truth is we're a very complicated environment. Desert Mountain has been willing to sort of work through that complexity. They now understand it. They're as immersed in the EPSDT world as any contractor in the state, and they're as outstanding as anybody. So they are an excellent model for other schools. They go around the state representing this model, and I think we're very grateful. We have a number of other school districts in our county that are trying to replicate on smaller scales what they've been able to do. Another question you have has to do with performance outcome measures. Our department has invested very heavily in performance outcome measures using the CANS, which is the Child Adolescent Needs and Strengths tool. We purchased a software product years ago and worked with a developer to create an ability to use the CANs to measure progress, both in terms of strengths and needs, as well as symptomatic issues relating to the progress of a child. So we can develop very extensive reports for all of our programs. We actually provide a significant report for SART and EIIS to the first 5. They fund a good deal of the program for SART, and we give them, and they have really great demands on data. We provide extensive data for them, but we can do it for all of our contract agencies as well. Might be of interest at some point, if you'd like, we could send you sort of an example of some of the reports we're able to do. The reports are also valuable at a clinical level. The CANS is of a great value just for clinical and supervisory level to sort of measure the difficulties of the cases you're working with, so that if you have a limited group of therapists that you're working with, you don't bury one therapist with all your most difficult cases. You can actually screen them along and make decisions as a supervisor. The clinicians can use them for developing their service plans. So it's not an intrusive model. It's built into the system, but allows us to gauge the success of individual programs, individual contracts, and regional success as well.
About a minute left.
I actually am here for support. Linda is in this position for about a year now, and I was the previous director, and so I'm just here for support.
Well, I want to thank you all for your presentations, and so it's a couple of questions. And actually, first of all, I want to recognize Senator Liu. Thank you very much for being here. And actually, we're talking about SELPAs and mental health, behavioral health in San Bernardino, as well as in Kern County, their coalition. So, so in regards to what you're doing with MVCCP over in Kern, you talked about you're trying to be sure you refer, right? So we're trying to see what everything is, and are you, in terms of the family feedback? Are you ever running into a situation where, I mean, people, they may get tired if you're referring a lot but not checking in other words, are they getting turned down a lot too? Is that creating any fatigue on the part of the parents, right? Or is that something that you're able to do in the background so the family isn't feeling like they're being, sent to one service another and then being disqualified for this and disqualified for that, or is there something? So can you just maybe speak to that?
Good question. First of all, the parent is involved at the beginning in approving the referrals being made. And yes, they are very much a part of the ups and downs with that.
And then, as far as I think it's great that you're able to have to support a public health nurse to help out with the care coordination and in terms of your local case management services. What are there? And I heard also in the previous panel. I mean, I think there's we've heard about the Packard Foundation supporting things. We've heard of other foundations. What are there things that we should be doing? And I know First Five's contributing as well. Things are there? Do you see opportunities or things we should be doing to try to help make these more sustainable from ongoing funding streams versus having to rely on the generosity of foundations and others?
Actually, thank you for bringing that up, because I kind of went into the public-private partnership and didn't talk about the federal financial participation that is leveraged with these private dollars. Without those, we couldn't function with a full-time public health nurse, RN. So those dollars can leverage up to $3 for every dollar that's brought in. And actually, several counties have adopted that within the 5Cs collaborative.
And actually, in regards to what you're doing in Desert Mountain, so it looks like there's an opportunity to bring together behavioral health and special ed, and I know that appreciate what you're doing, and I think there were some concerns that as some of the behavioral health funds were moved more toward being focused toward school districts, that they weren't looking at the whole child, and it looks like you're looking at a sort of a broader approach. As you're doing this, some of these children have they have mental health issues, they are in special ed, they may have other issues as well. So how is that interface working? So we're having special ed, and we have behavioral health, and is it sort of like, okay, well, we take care of this space and they're off? I mean, so in terms of trying to figure out how in working with the families, I know you're trying to simplify one piece of things. What do you see in terms of interfacing with the other systems, developmental services they may receive, and medical services and so forth they may need? How's that experience?
The Desert Mountain Children's Center, because we're under the umbrella of a larger organization that is part of SELPA, we're very involved with every one of our school districts. And so we're like a family. So mental health is just seen as a piece of what happens on all of our schools. So if a child has special education and we are a part of that, we are right in the mix. So we're at the IEP meetings, we're writing the goals specific to education and academic progress. So it's a nice collaboration. The Department of Behavioral Health supports that. They also know that we're working on mental health goals for all of those children, whether they are receiving special ed or not. And so we document that appropriately.
And also to speak to the SART population, which is our younger ones. These are the kids that are going into preschool and kindergarten, and we're often seeing the teachers who let us know that there are problems that are notated at that time, whether it's a developmental disability, social skills issue, anger management issue, anything else that's occurring with the child. And through that program, we have on staff a pediatrician, a developmental psychologist, a mental health clinician, somebody who is focused in social skills, anger management. You also have a psychiatrist and a public health nurse. And so you have the full conglomerate of staff there who is working as a transdisciplinary team, and we are often writing reports that are communicated with not only the family but the school district, so that we can all be on the same page and decide what's best for the child, in addition to the child's family giving input to what's best for that child.
And Senator Pan, if I can add to that, with our youngest population, we often will walk with the family to the school with the teacher and hand them off, sharing what works, what doesn't work, how we think they can help the child transition into school. It's a nice relationship we have with our schools.
And are there things that we should know here at the state level, that the barriers you ran into as a result of rules or laws or regulations at the state that seem to be inhibiting collaboration?
I
30 seconds or less?
I'm gonna let Mike take that one.
We will follow up.
Well, there are a lot of complexities in the funding streams of things. And what we've learned is that if you master the funding, then you can, within that framework, create a really comprehensive structure. And that's really what we've been able to do. What we can't fund with EPSDT, we've been able to bring into bear MHSA, Mental Health Service Act dollars, and the schools are able to be creative and bring in what they can bring. The difficulty lies in terms of being able to spread this out statewide or through all the other regions, is that the resources are not always equitable. We have school districts that if they place 2 children out of state, they've used up their money for AB 114. So there's nothing to bring down local match. So a lot of it has to do with, certainly in the South, with the ability to bring school districts together, to have a sense of trust that a relationship with behavioral health is worth the complications, because it isn't an easy start. We probably bring a new school district on as a contractor each year. And it takes about 2 years to get them functional where they're feeling successful, that it was really worth the trouble. But that's all around the complexity of what it means to be a Medi-Cal provider and what it means to be a school district. And I think a partnership with an ability for both parties to have a shared language and a shared understanding is really essential for it to work out in the long run. And that's, if you build caucuses or consensus where both mental health and education can attend, like the California Mental Health Advocacy for Child and Youth Conference in May, where they can, that was a plug, shameless plug. Those kinds of settings where people can get together and hear that they're looking at the same issue, but they look at it from a different way, and they use a different language. But it allows for an opportunity to build a bridge, and I think that's one thing the state can do, is help to build those bridges. The disconnects between mental health at the state levels and the LEAs and at the state level, get them to work together and to listen to one another and to plan together. It can be done. We've done a good job. Many counties have done outstanding work between their mental health and their schools. There's every reason to support it and encourage it.
Senator Lou?
It's interesting. It's encouraging to hear you speak that way. I know the auditor has issued a report on mental health, the situation between the county when the funds were transferred now to the school district, and then the reassurance that the kids are really getting services, and that's been not quite as planned in some instances, and so we're taking a look at, and Senator Bell, who's very interested in mental health, is taking, and he's got a couple of bills in front of us tomorrow to talk about how better to coordinate this very complicated issue, all centered around the child. So we are concerned. I mean, we don't want to step in the way, but we are in the way, so to speak. And yet, resources are very limited. And we just have to, what you're doing is what we want to see in a coordinated fashion, especially with school districts, and parents, of course. But we need to know if you could suggest ways that we could make it simpler, kind of thing, and make it flow better for everybody, especially the kid. We're concerned about that, and would like to be part of the solution as a part of being in the way.
Love that. If I can respond to that.
Briefly.
Yeah, briefly, okay. So we've already served about 10,000 kids this year. Not all of them are EPSDT eligible, but all of our charts follow the EPSDT guidelines. And so they are clean, they are clear. Our audits, we have 0 disallowances at this point. I mean, we have learned how to document what we do well. What worries me about some of the language in the proposed bills is additional documentation. I think that makes it onerous. I think it then takes away time from kids, because EPSDT documentation is already onerous. And adding more onto that actually impacts the services. And so I would encourage, if we're going to have a standard, that it's a standard that Medi-Cal accepts and everyone's happy with, that we're not double working.
Piling it on,
yeah.
right.
Yeah.
Be mindful of that tomorrow's conversation.
I will be.
Yeah, right.
Okay. And I was also at the hearing on the Select Committee on Mental Health when he was
Right.
talking about that. So, okay. Any other questions?
No,
All right. Well, I want to thank you so very much. I know the time was brief, but we also know, I think we know you're willing to be found, and we can follow up on some of these things, right?
Thank you.
Okay. No,
Absolutely.
thank you all. Thanks very much. Thank you. So the next panel is actually State Department Interagency Coordination Standards, and it's a pleasure to have Jennifer Kent, Director of Department of Healthcare Services, here to address California Children's Services. We also have Karen Baylor, Deputy Director, California Department of Healthcare Services, Mental Health, Substance Use Disorder Services. We have Brian Winfield, Acting Deputy Director, California Department of Developmental Disabilities, and then also Stacy Wynn with the Education Programs Consultant for Department of Education Special Education Division. So welcome all. Thank you so very much, and really appreciate you all being here and reflecting on, from the administrative side, we're quite eager to hear about what we can try to do to help improve coordination care. So, Director Kent, why don't you begin? Thank you so much for being here.
Great. Good afternoon. Hello. Jennifer Kent for the Department of Healthcare Services. I really appreciated listening to the previous presentations, just from the standpoint that when they make certain comments and say, oh, this doesn't work well, or this is like the hallmark of a good care coordination plan, I was like, oh yeah, we would agree. And then the previous panel that said, well, if you can master the financing, you can pretty much master the world, I would also agree, which is the key to all of our work, obviously, unfortunately, always boils down to the financing. As a director and as a really large and complicated department in which we administer both the Medi-Cal program, but we also administer the CCS program, which may or may not be Medi-Cal from the standpoint that we have kids that are not in Medi-Cal but also are in CCS. Dr. Baylor will talk more concretely about some of the programs outside of Medi-Cal that deal with either mental health or substance use disorder, because again, we have some other programs that are within our department that are really important supports to the overall system that we've built in California, but are administered differently, have different rules, have different financing streams. I think one of the things that I want to stress as a department is that we oftentimes are players with other departments or other agencies when it comes to delivering a service, because especially within the Health and Human Services Agency, we have many sister departments, but a lot of shared populations. So there's times in which we are the lead department because it's a program that we're administering, but we receive support from either social services or from DDS or from public health. Obviously, we play with the Department of Education because children get out of our medical world and they go into the educational world, and the need doesn't stop at the door. But what I really wanted to stress are a couple of things that we hold as key to an interagency coordination role. Is that the first thing really starts with an interagency agreement. Some may call it a memorandum of understanding. We use interagency agreement most usually. This involves both roles, responsibilities, who is going to be lead or coordinating what. These are all kind of legal agreements between us as departments. It also protects data that may or may not get shared between the departments. So when we did the behavioral health transition with DDS, for example, part of our interagency agreement involves our ability to legally share data and for them to share data with us, specifically around beneficiaries that may have extraordinarily either sensitive or complex, files or charts. I think one of the other things that is the hallmark for some of the work that we do as a department is built around transparency. So I think that what we have done a much more significant effort over the last few years is to be responsive and acknowledge that not only is it a partnership between the state departments that we work with or the counties or the programs that we work with on a local level, but the federal government is a partner that is oftentimes missed. And so for the previous conversation around FFP, just as we try to partner with other departments and other local environments, the federal government is a partner to us. And without their financial participation, a lot of what we do as a state could not be possible. Unfortunately, the funding does not come with a trust me, call me if you need me kind of agreement. And so a lot of times the requirements or the requests or the burdens that we put on either programs or other departments is really a response and or a recognition of the fact that we don't control our own financial destiny because we have other partners that require certain either oversight or data mechanisms. I just wanted to highlight a couple of the key interagency care coordination activities that we're currently either working on or that we are under development with. Obviously, I referred to the transition of behavioral health therapy as a benefit from the DDS regional centers to as a Medi-Cal benefit. And so we've been in the process starting since February of enrolling children for their BHT services into managed care. And so that has been obviously, and I'll let DDS speak to it a little bit more, but that was certainly something that we had to work on both from a data standpoint as well as making sure there were continuity of care other arrangements in place, and that providers had warm handoffs if they weren't going to be on the contracting side. I think social services, Department of Social Services, is a key department in which we have a lot of shared both activities on, and again, Karen can speak more to what's going on with the CCR work, but also around children in foster care and the prescribing of psychotropic meds, but most specifically antipsychotics. There's also what agency convenes is known as the Child Welfare Council, which is a large group that is dedicated to looking at a lot of different needs of children in subpopulations, either foster care or children with other specialized needs. We administer, and it started off very small, and I may have actually been sitting at this table back in 2006 when it was authorized, was something called the Pediatric Palliative Care Waiver. It started off in 3 counties. I believe it was Monterey, San Benito, and whatever Salinas is in. Is that Monterey?
It's Monterey.
Yeah. There was a little 3-county pilot that this started off with, and it was really started by a nonprofit and a bunch of really, really dedicated parents who saw a need out there for children with either extraordinarily chronic, complex disease or children with terminal illness. We have since expanded that waiver program to encompass the rest of the state. It focuses on children who have they may not be terminal, but they have extraordinary needs that require in-home or supportive services outside of what takes place in an inpatient facility. I think I would also like to say the Department of Public Health, on a large system and scale in terms of quality. We work closely with them on Title V grant opportunities, as well as the Perinatal Quality Care Collaborative is a really good example where we're focused in on hospitals, especially hospitals with neonatal intensive care units, in terms of also trying to engender best practices and better clinical outcomes. And CDE may or may not want to talk about the partnerships that we have around newborn hearing screening programs, or the better outcomes for individuals who already have hearing loss. And then lastly, kind of my favorite, we have a lot of interesting county collaboration going on, both with CHDP as well as the CCS program. I know a lot of the earlier panelists talked a lot about CCS. This is one of the oldest programs, and it requires a lot of different interagency cooperation and collaboration in terms of it's not only us as a department and the county CCS program, but it also involves regional centers, it involves educational agencies, it could involve specialty mental health from a county behavioral health department. And so nothing is more complicated than that, really, when you talk about a child who has a complex medical condition, who also may need mental health, may need regional center services, and obviously is going to school. So that is certainly something that we are working quite intensively on. And then when we talk about First Five, this leads us to one of the initiatives that we're working on under our new Medicaid 1115 waiver, which is, again, was approved by the federal government at the end of last year. There's a dental transformation initiative within this waiver of about $750 million over 5 years to improve dental outcomes, specifically in child populations. And so this is really both interesting and engaging work with the First Five partners that have been really kind of at the forefront of helping to fill in some of the dental gaps in our state. And so I think some of the pilot initiatives that we're going to be working on will not only involve counties, but also involve First Fives and providers and other types of regionalized approaches. And so that's something that we're excited to report back to this committee and others on. So with that, I will stop and probably defer to Dr. Baylor for the mental health component.
Great. Thank you. Thank you, Dr. Baylor.
Thank you. It's a pleasure to be here this afternoon, and I just want to highlight a couple of programs and initiatives that we're working on. One, as Director Kent already mentioned, is with DSS on our KDA settlement agreement and implementation of those programs. There is what's called a shared management structure where we meet on a regular basis in order to make decisions. There is an executive team. There's also a once-a-month meeting with the community team. But one of the components of the KDA settlement agreement was that each county is to have a child Child and Family Team. And while it's named Child and Family Team, it really is to involve all of the folks that you've heard from today in order to come together and have a discussion about what is the child's needs and how to meet those needs. And so we're seeing a lot of the counties now implementing the Child and Family Team and are really optimistic about what kind of care coordination can result from that. Dr. Kent,
Sorry to apologize to interrupt. So what's the scope of this child and family team at each county?
it involves anyone that the child and family wants to participate, and so they could.
For the KDA subclass.
But
Or for the KDA.
right, so it's for foster care kids, but they can bring in whoever they want in order to be at the table to discuss the child's needs. We're also working very closely with the courts, DSS, the medical board, on the psychotropic issue and in trying to find ways to make sure that we've issued guidelines on prescription and prescribing practices. You've probably heard a lot about that. We have a data use agreement with DSS so that we can share information and then share with those appropriate counties so they can look and make sure that those children are getting the appropriate level of care. Director Kent also mentioned the Child Welfare Council, and I just want to mention that that is a meeting that we're actively participating in. In fact, we're leading the sub-work group on what's called PASS, which is Priority Access for families who are going through reunification and trying to figure out ways that they can get their needs met so that they can meet the court requirements for reunification. And we just now started piloting this in Ventura to see how this works. One of the other initiatives is our Drug Medi-Cal ODS waiver. When we talk about behavioral health, DHCS considers that mental health and substance use disorders. Today, you've heard mostly about mental health, but I don't want to forget substance use disorders. And we're looking to expand youth treatment. And there's a big piece of care coordination within our waiver, our Drug Medi-Cal ODS, Organized Delivery System waiver, where counties have to be responsible for making sure that they are monitoring and providing that care coordination. So we are rolling that out into phases, and we've moved into our third phase, and so we're very excited about having these services get out there for the youth. And then finally, just to mention briefly about the Health Home Project that was under the Medi-Cal 2020 waiver, there is a final document that is posted to the website, and it is all about care coordination, and it really does touch on a lot of the principles that you heard here, and I believe it's going to start implementing in January of 2017. And with that, I'll end.
Thank you. Thank you. Mr. Winfield.
Good afternoon. Thank you for the opportunity to present this afternoon. Brian Winfield, Acting Deputy Director for the Department of Developmental Services. First, I just want to start off by saying that the department has collaborative relationships with each of the state departments that provide services at the local level. As I testified in December, the regional centers are the local single point of entry into the system for regional center consumers and families. So the coordination that occurs at the local level through the regional centers is really critical, but at the state level, we also coordinate and collaborate with the state departments of social services, healthcare services, education, rehabilitation, public health, and other state departments to ensure that services are coordinated. Sometimes those are more routine types of contacts, but when there are transitions of services or issues that we need to resolve at a state level, then we have more frequent contact with our sister departments and agencies. I'll just go through and highlight a few of the current collaborations that the department has at the right now. First off is the Interagency Coordinating Council for Early Intervention. This is a group with DDS, DHCS, DSS, as well as education. And because regional centers provide early intervention services to children, infants and toddlers birth to 3 years of age, this is an opportunity for the state departments as well as family members, service providers, and other stakeholders to come together to provide the department with broad input on the administration of that program. A second one As Director Kent talked about, the transition of the behavioral health treatment. So we've worked with DHCS over the past months to ensure a smooth and seamless transition, since the behavioral health treatment services are now being covered as a Medi-Cal benefit for individuals under 21 years of age. We've worked with DHCS and with the regional centers to ensure that there is a seamless transition, and in most cases, individuals have been able to stay with their current providers as well, which we consider to be a real success. A third example is the state interagency team for children, youth, and families. DDS participates on this committee that is chaired by the Department of Social Services. It also includes healthcare services, public health, education, alcohol and drug programs, and a whole host of other entities. And really, the sole goal of this team is to help to facilitate the services and supports for children and families at the local level. One of the more recent outcomes of that group is the California Earned Income Tax Credit and the free tax preparation for low-income families, and we've had a really good response to that initiative. I'd also like to highlight for you a recent collaboration with the Department of Rehabilitation and the Department of Education, and that's the Blueprint on Competitive Integrated Employment. So we've been working with our two sister departments for the past 14 months to develop a blueprint that lays out the activities and the outcomes that we're looking for to ensure that as individuals become transition age, that they can move on into competitive integrated employment. We expect the blueprint to be issued within the next few months, and it's really a 5-year plan about how our three departments will work together to achieve better outcomes for the people that we serve. Recent legislation authorized DDS to have a paid internship program, and so we'll work with stakeholders to obtain input. And beginning in next fiscal year, we will be implementing the paid internship program, which also will benefit transition age youth. And lastly, a partnership with the First Five California, which also includes participation in the development of their annual conference, which is coming up in November of this year. So as we talked about last time, that the case manager at the regional center is really a pivotal person who is that connection for families and can help families to navigate the care system and also help them to resolve issues. We at the state also consider our coordination piece very important. The governor's 16-17 budget does contain funding for regional centers to hire approximately 200 additional case managers. And so we hope that those case managers will help to bring down the caseload ratios for regional centers, as well as to ensure the timely provision of services and to ensure the receipt of federal funding. And we understand that it's sometimes difficult for families to navigate the system of care in California, especially if they are raising a child with special needs, maybe raising other children and all the other responsibilities. So our department is certainly willing to assist and participate in the coordination of activities and services. Thank you.
Good
Thank you so
afternoon,
much. Thank you. Welcome.
Senator Pan and committee members. A lot of the work that we do has already been covered, so they just made my job a lot easier. I'm Stacy Woodine. I'm an educational programs consultant in the Special Education Division at the California Department of Education. And I do want to say that, I'm speaking on behalf of the Special Education Division. I think there's a lot of good collaborative work being done by the department as a whole, but I'm speaking just from that perspective. When it comes to serving our students with disabilities, not only is it the right thing to do interagency care coordination-wise, but we're actually mandated by the Federal Individuals with Disabilities Education Act law to have interagency agreements or other mechanisms for coordination in place with our sister departments. The law recognizes that overlap exists. You have a special education student who is entitled to receive the same service from two different entities, educational entities, public entities. So we have quite a few interagency agreements in place. I'm going to try to run through them quickly. We work with the Department of Developmental Services and Department of State Hospitals to ensure that an appropriate educational program exists for our students with disabilities who are in our state developmental centers and state hospitals. We work with Department of Corrections and Rehab, similarly, to ensure that an educational program exists for our students with disabilities in state juvenile justice facilities. We work with Department of Healthcare Services on a couple things. One was mentioned, the CCS program. So under state law, county CCS programs are required to provide medically necessary occupational and physical therapy to students with disabilities. So we have a state level interagency agreement that addresses that collaboration. We're also in the early stages, actually, of talking to healthcare services about the need for an interagency agreement that addresses obtaining Medicaid reimbursement for services provided to students with disabilities who are also Medi-Cal eligible. And that's kind of a big issue, a very complex issue. We've been talking about it for a little while, but we continue to discuss the need. We hear the need from our locals that there needs to be some clarity regarding that issue, and so we're giving it our best effort.
Very supportive of that.
Good. I'm glad to hear that. We also work with the Department of Rehabilitation for transition planning and services to our secondary students with disabilities to create a coordinated system of educational services and vocational rehab services. With the Department of Rehabilitation, we collaboratively oversee the state's transition planning programs and local Workability 2 programs. What's unique and interesting about our relationship with Department of Rehab is that we do have a funding relationship with them where the Department of Education actually puts up $206,000 in state general funds. We give that to the Department of Rehab. Department of Rehab turns around and pulls down over $700,000 of federal VOC rehab funding. So then we have a pot of almost $1 million to do this collaborative work together. DOR also turns around and funds a staff person in the Special Education Division at CDE that serves as the liaison and the lead for the collaborative work. So we have a nice relationship there to do that work. We also work with Department of Developmental Services on the Early Start program. So that's early intervention services to children with disabilities ages 0 to 3. And then it was also mentioned earlier, we have a new memorandum of understanding about integrative competitive employment, basically just memorializing our joint commitment to pursuing the employment first policy for the state and providing for opportunities for our students with intellectual and developmental disabilities. In addition to all of those sort of like federal or mandated interagency agreements, we do approach interagency collaboration in a less formal way. So we're not shy about pulling together interagency work groups, multidisciplinary work groups to address issues as they arise, changes in law. We've done that several times in the past. And in regards to your second question, it was about, what can we do beyond what's currently funded? I know for us, it's more about approaching every interaction and every conversation that we have with our other departments with an open mind, with curiosity, learning more about the work that we do and seeing if we have a place in that work. And then, making sure the conversation is broader than, what does the law prescribe that you do and that we do, but really how can we maximize available resources to serve the same population? So with that, take questions.
Well, thank you. Thank you so very much. And I do want to recognize and appreciate from your division, we did get the written answers to our questions. And so thank you so very much for that. I think we're still waiting for them from DHCS and from DSS. So looking forward to getting those as well. Appreciate you being here. Couple questions. So first of all, actually, I understand you've referred to a lot of different interagency bodies that are working on a variety of different things. And I don't know to what degree, for example, like the Child Welfare Council or the interagency team on children, whether there's a way to get either an agenda or summary of some of the things that you're trying to tackle. I mean, so some of it certainly sounds like you're trying to do transitions and so forth, but also trying to think about what are we trying to do to coordinate between the different agencies, services. If you can share that I think is always helpful. Get credit for the wonderful work you're doing that sometimes I think most people don't know about. And then I guess the other question I have is that, so for example, in Medi-Cal CCS, we have CCS folks at the county who we've heard testimony from families who've done great things for families in helping them connect and coordinate and get services and so forth. And then also I know you spoke about, and we've heard some great things also about the case managers, and I'm glad to hear that we're going to be trying to get more of them in the budget as well. And to the degree that those folks can so this is back to the parents having to be the care coordinator for the care coordinators. So the degree that we could look at, so can they, are they just, they're doing stuff, and some of them sounds like they're actually perhaps doing more. I don't know whether they're supposed to or not, but they're trying to help the whole family on everything. That they would have either supports or resources, training to actually not just, let's say, do the case management for the around the regional center services, but more broadly, so that there's fewer care coordinators for the parents to have to care coordinate between, right? Or the CCS at the county, and actually, special ed, I don't want to, and the special ed field, that as the IEP teams come together, and some of the stuff that they can do, and certainly I think we've been hearing some of the models, the same behavioral health. Can you perhaps speak to that? I mean, is it, for example, does it make sense for someone to be both a care coordinator for CCS at the county and also be a case manager for the regional center for a particular group of families or something like that, where you have overlaps that you can so that we actually have people who can actually navigate multiple systems? So perhaps you can speak to that and the potential for looking at that or doing something. I realize that that's drilling down a bit because some of that's, that's county, we're running state agencies, et cetera. But what do you think are the opportunities for trying to look at that?
Let me take a shot
Sure.
first.
All right.
So I think in some cases it's a matter of who's employed by who.
Right.
So you get that whole who do you work for, who are you accountable to. I think what we have seen, and I think this is both in CCS as well as in CCI, which is our coordinated care initiative counties. And back to the first presentation around what are the hallmarks of really good care coordination, and the first thing is you have to have a plan. So in our CCI counties, what we have seen is that it's not necessarily just a single person, but it's really this interdisciplinary care team. Yes, you need to have one person or one entity kind of doing a lot of the marshaling of the data and the information and the distribution to all the different members. I think what you're really touching on is there has to be a plan, and you have to involve the various entities that have a voice or a role or a responsibility for that child's care. And so what I think of when I think about CCS or children that fall into both CCS and developmental services or into the educational model is it's less about having one person try to serve 3 different programs, but more about having those programs have identified people that sit together and say, let's talk about this one kid. He has a very significant hospitalization coming up, so we need to have a plan in place to deal with their educational needs. He also is, got some developmental issues. And so what we have really seen on the CCI side, which is an adult program, is you take those learning experiences and you try to tailor them to be more appropriate for a child, because obviously adult things are not always appropriate, but there are good things to be had. And so I would say to your comment, we would really be interested in making sure that you have a convening of all those different entities. And sometimes they have a larger role in the team than others. And so that's something that we want to both help replicate or encourage. That's, I think, what the State Department's role is not to be the one that does all of this work ourselves, but to help incentivize or create the space in which the local county providers and others can come together and do that work on the right scheme.
I can comment. I agree with everything that Director Kent said, and I do want to say, the IEP team is sort of a model for that. It doesn't always function that way, but I think it's intended to be a multidisciplinary team that's child-focused. It would be great if we could, match the care coordinator instead of matching him to a program or an agency, to match him with the family and start from there and take note of all the needs that the child has and start from there. But I realize that that's, not always possible. I just want to say, I think that, putting funding behind organizations that empower families is a really powerful thing and an effective thing. I know in the special education world, we have our parent training and information centers. We also have our family empowerment centers. And I knew that they do great work. They get involved with the families, they get involved with the student. And a lot of the times, they're looking at issues that go beyond the scope of their educational need. So.
And I guess, and I appreciate. certainly I agree that it really is not just about the one person, but in fact, we talked a little earlier about the role the parent, actually supporting the parent and giving them the capacity and the financial resources to be able to do that role. But we also heard, and when we talked about the models in terms of funding, and a lot of them actually are, getting funding from foundations and so forth. And I think foundations do great work, but they're not constant funding streams, right? And so it does take time for people to come together and do those meetings. What do you see are the opportunities to try to actually incentivize? And we've heard from the pilots, but we searched pretty hard. We got and I think that we had 4 great presentations and pilots, but they're not common out there, and they're challenging. And I think we heard from them. What are things we could do to foster more the collaborations that we had heard presentations today, and getting them some resources or opportunities to get some resources, and realize we have different partners and so forth, but and also probably in terms of evaluation, especially if we can show they can save money, maybe we have a better chance of getting more resources. So what do you think are the opportunities there to say across, got the 4 of you from different places, to say, look, there's some money maybe we can pull together, identify to try to build more of these collaborations that they can do this this kind of work.
Since I have the department with the really big budget, I think there's easy ways and there's hard ways to finance things. Obviously, what we choose to do first and most obviously is use the resources that we're given and try to either redirect or, make it more efficient, or do something that, if technology or there's some other mechanism by which we can leverage to help things go smoother, that's something that we're always interested in doing. Our first and obvious reaction, obviously, because we work within budget constraints, is not to just say, well, just spend more. We usually look and say, is there a way that we can be creative? Is there a way that we can maximize federal funds? And to the comments about the Alameda example, on the county side, on a county behavioral health side, they have dollars that are available to them either from a realignment source or from MHSA. Those can be used to maximize federal funds. And so sometimes when you're able to do that, it frees up funds that are otherwise being used, and then you can kind of and it's not, again, once you master the financing, you master it all. I think that there's places that we would be willing to look as a state in terms of programmatic changes if and this is really what CCI is about. It's in those 7 counties, and it's really trying to demonstrate that when you do better care coordination, you do have savings that naturally accrue in the program because people are getting the right care at the right time in the right place. That in and of itself helps fund more of that activity if it can be proven. And so I would say from where we sit, to the extent that we're 3 years into a 3-year demonstration or entering into year 3 of a 3-year demonstration, that is something that we're really interested in seeing if there's best practices we can use and apply to either the CCS program or to foster care or other types of specialized subpopulations that we have that have a great need for better care coordination. I think when you look historically at what we did as a state before the Affordable Care Act, is we created a lot of state programs that were very contingent or focused on income levels or trying to address gaps in the system because people didn't have coverage otherwise. So they were disease specific, they were population specific, they were very much more patchworky and fragmented. And I think we are still in the process as a state of trying to overlay this new Affordable Care Act. Most everyone has coverage. You have residual populations that do not, so we will protect those populations and those programs. But now that we're in this new era, it's kind of like, how do you redirect and use resources in a different way that we've never thought of before? And I think we're still in the process of that experiment.
Just speaking from DDS's perspective, we're certainly happy to work towards more collaborative models with our sister departments. We do see the regional center case manager, as I said before, as a real hub for the consumer and family, because they do develop the individual program plan that does include the services and supports, but also talks about the other services that the person might need to be successful in their life goals. So I think there are certainly opportunities for better care coordination, and the projects that we heard today, Alameda County, Kern County, and the others, regional centers do participate in those, and those are successful in their opinions anyway. So I think exploring those other opportunities throughout the state that we can either replicate or we can find new models to help families with their care coordination, we're certainly happy to do so.
Well, certainly, one of the challenges is that if you can master the finances, but we have multiple funding streams with multiple regulations. So I'm hoping that, and maybe that's something one of these bodies can take on too, is take the master of finances from each of the different things and have them all come together and say, look, where is the opportunity, right? If we want to get some money for locals to do this, it's not just, oh, well, you're the biggest agency of the biggest budget, whatever. It's like, okay, where's the opportunity? We actually put some money, some state money somewhere. We can leverage this much federal money, even if it's from this piece, but that's where the best opportunity is, then that may be. And then, of course, being able to do an evaluation that shows if we can save some money, maybe we can pursue it in a waiver or something in the future. Look what we've been able to do, et cetera. But I think the idea is to try to look for opportunities to, as I said, get all the finance masters together to think about what the
I
opportunities
will not
are.
be at that table.
Table. I mean, because the challenge is that obviously the families, I mean, they have to, you have a child with special needs, you have a premature baby, you have, child who gets a diagnosis, child, something happened, and suddenly now you have to be this expert, right? And I mean, we're here sitting in this room trying to piece it together. And in the meantime, you have to take care of your child, you have your family, and then you're trying to figure out how to master all these different pieces. And so at least we should be able to do some of that work to help the families. So if there's opportunities to do that. Let's see, let's see, I'm going to go ahead here. So Dr. Baylor, Ms. Baylor, can you speak to, Dr. Baylor, can you speak to, there's issue about rate reimbursement for mental health services for SELPAs and LEAs? I think there's a concern about that came up. I realize it's not quite.
I'm not understanding there's a rate issue. Things dramatically changed when 3632 was
Right.
repealed, and it then became the responsibility of the SELPA to either provide those mental health services, contract with them, or build a relationship with their county mental health plan. And it's all three of those across the state, those models.
Okay, is there a standard reimbursement rate?
No,
For
each
county?
county
It's-
gets to negotiate their
So each
their
one's
rate
negotiating
with their SELPA, yes.
So we have a different variety of different things.
And you have different models across the state. Some SELPAs and mental health plans, as you heard in San Bernardino, work really, really well
Right.
together.
Yeah, no, it's
And then
good.
there's other SELPAs
Others.
who don't, and mental health plans who don't have a
Okay.
good working relationship.
Sorry, we'll have some bills coming up tomorrow, so I want to make sure I tackle that. And then I guess the other question is that the models we heard, a lot of them were looking at systems changes, and I think that's great. When we did hear from Kern County, where they actually got a public health nurse to try to help out individual families. So I guess in terms of, is there some role that, I guess collectively, and I don't know which interagency group or is that, so if we're trying to encourage, let's say, counties to put together, collaborations, not only like systems, but also, let's say, like Kern County, where they have someone help, and to identify where, but then in terms of, if you identify basically systems issues that then relate to the state, and I'm hoping certainly the select committee can help out with if there's things on the legislative end, but we want to work with you and sort of saying, okay, you know what, I realize, people pass laws at the federal level, at the state level, we have county regulations, and, there are issues people confronted at whatever time they were passed, but like step back and take a look at the corpus of that and say, are there things we could do smarter to help out this population? So I've heard about these interagency groups. Is there someone or some way to sort of look at how we could try to on the administration side? I don't know if it's one of these child welfare counselors, but to sort of like, okay, let's look systematically what are the barriers to implementation and how. And whether we get feedback from counties that are trying to do this, or just even all of you from your normal hats saying, okay, I wish we could only do this, or something like that. What would be the best venue to make that happen? So I guess I'm saying is there an interagency group that deals with children with special needs that could help out in trying to tackle regulatory and legal and issues
So that doesn't, it exists and it doesn't. It's not called that.
Right.
Again, and I think what you hear us kind of like, well, if you can hear our brains chugging away on this question, to say that there's children with special needs to us, or to at least to me personally, I'm like, well, which population of children with special needs do you want to talk about?
There's many of them.
Because there's many of them, and so what a foster care population may need in terms of changes administratively or regulatorily or legally is very different than what a CCS child may or may not need. And so I think what you hear us, and this is what my hesitation is in trying to answer your question, is we have a lot of different work groups and both external advisory committees that we work with, both providers and counties and others, where we tackle those, but they're not necessarily called children with special needs because it depends. Is it a DD population that we're talking about? Is it a foster care population? Is it a CCS population? So we have a lot of those different things and entities, both formally and informally, already in place, but nothing so broad as something that's called that.
Well, I guess I know where to find each of you, so we can plug
Yeah.
in if I need to something.
Yeah.
So, okay. Well, I want to thank you all for being here and your presentations, and appreciate the testimony, and we're looking forward to working with each of you and your respective agencies. And I know that we're all committed to trying to help out these families, and so hopefully as we plan not only future hearings but also future reports, we appreciate your cooperation and your participation as we try to again improve the care and support families of children with special needs here in the state of California. Thank you. Thanks very much.
Thank you very much.
Thank you
Thanks.
much. Thank you. All right, with that, we will open it up for public comment, and actually, so I guess we'll ask people maximum 2 minutes. I just want, and so I guess if you want to form a line by the sergeant's desk, and then we'll have people come up. Oh, I guess there's. All right. So why don't you come up and introduce yourself, and thank you so much for being here.
Thank you. Thank you both for your leadership in this important discussion. My name is Pat Howard. I'm the supervising therapist at the medical therapy program in Napa County. And I'd like to encourage the committee to consider the perspective of medical therapy program therapists as you proceed with your work here. As you know, the MTP serves over 23,000 children statewide. And OTs and PTs, with our role in helping our kids become as functional as possible across all environments, are in a unique position to actually see the results of successful interagency collaboration and coordination. And as we collaborate on behalf of our clients with representatives of all the agencies who've been in this room today. The medical therapy program is also committed to evidence-informed practice. I know that's really been an important piece of the discussion here. And as well as family and client-driven care, and that's increasingly our standard of practice, because that's what's really supported by the research. Under the direction of the Medical Therapy Advisory Committee, we have a work group that looks at both the current research regarding the efficacious therapy service provision for MTP-eligible diagnoses, as well as looking at the outcomes we've developed and are continuing to develop within the medical therapy program itself. We've got a lot to add to the conversation. I know we represent a really tiny group of kids. It's big to us. There's about 1,000 therapists statewide, and we're really boots on the ground. We work directly with the kids and the families, and we do work with a lot of different agencies, so we'd be delighted to give you as much information as you want.
Thank you, and we know that's an extremely important program
Thank
and, and very vital to those kids. Thank you so much.
Thank you.
Okay. Welcome.
Good afternoon. My name is Gail Young, Children Now, an advocacy organization dedicated to improving children's overall well-being in California. Children Now would like to thank Dr. Pan and his staff for putting together this select committee hearing for children with special needs. Given Children's Now special interest in improving care coordination between agencies and how to better make the systems work for children and families across education, health, and social services, we look forward to working with you and the rest of the committee member staff.
Thank you. Thank you so very much. Welcome.
Good afternoon. Tony Anderson, the Executive Director of the ARC California. I appreciate this hearing today, especially this conversation about the coordination of all the different groups. And then one in particular, I'd like to just highlight the Interagency Coordinating Council that was mentioned earlier. And we've had a struggle over the past several years now of a bit being as effective as we used to before the recession, all the cuts that were made. We don't have the kind of attendance that we used to have back in the glory days when all the families used to come. We used to have very robust conversations about what's happening in the early start area. But we also we struggle with getting representation on the coordinating council. And I know there's nothing you can actually do right now, but just to sort of alert you to the fact that we need to make sure that we have the representation that's supposed to be there for the coordinating council. And we also have a position for a legislator, and I'm not asking right now, but we do have that kind of a position on the coordinating council that has not been filled in a very long time.
Well, thank you. I didn't know if it's an appointment by the speaker, the pro tem, or just okay. All right. Okay. Anyone else? Okay. Oh, I see one more. Welcome.
I guess I just have a few things to say. I'm Yvette Baptiste. I am the director of a family resource center that serves families who have children in the regional center system in eastern Los Angeles. And I am also the adoptive mother of 3 children with various special needs. My son having UCCS and having very high medical needs. And there was just a few things that were brought up that I wanted to comment on, if I can read my notes. So one was, does care coordination make a difference, and can we find out maybe with some kind of evaluation, research or in some kind of concrete way? If it does, I think that would be wonderful. But I think if you ask any parent, and I think, it's been spoken to that anecdotally, certainly every parent that I meet is coming to try to get that. And in trying to coordinate the care for my 3 children, that was one of the hardest things to do, because they used all the systems that were represented by the departments here. And I was that primary person. Can any one department, say Department of Developmental Services, help to coordinate that? No, I don't think so, because I think that the silos exist. When we Director Kent mentioned, I think at the end, she said something, how do you separate the special need of the child, because they kind of go across all these different departments. But I think that's exactly the problem, is that the various departments and funding streams support the families in different ways, and it's hard to tease them apart because you can't tease those funding streams apart. But if we can figure out a way to make it at a level that it doesn't impact the family, then I think that would ultimately be what you could do to really help families to not have the level of stress and to struggle as much. As we can understand that there are rules and there are regulations and there's funding, but if it can be a much higher level so it doesn't impact us. I just wanted to say one more thing. As you think about who needs the most care coordination in the system for children with special needs and particularly with developmental disabilities, there are children who leave the early start system. By the way, I do want to, Tony is exactly right. If we could get the interagency care coordination, that statewide body fully having everyone, even the governor's appointments have been a problem. If we can get everyone there, then we can do more work. But there were also local interagency coordinating councils that were not funded, were really involved in the development of the at the time of the development of early start that we need to do. That we need to get back to. But what I wanted to say about care coordination, the population, is the children between 3 and 5. When parents come to my center and their child is over 2 years, 9 months, and before they enter kindergarten, actually are in the school district, where they can easily be identified and go towards special education. Those kids and those families are the ones that have to wait for services. They either don't get to have early intervention because there's not enough time to get them the services, and maybe they get to the school district and get the services. So looking at that is important. And I know I've exceeded my 2 minutes.
Thank you so much. Okay, well, all right. So I think with that, I think I see people. All right, so with that, oh, yes. Dr. Shore, please introduce yourself.
I'm Ed Shore from the Lucille Packard Foundation. I've been sitting there trying to figure out how you cut through this Gorgon knot of bureaucracy and actually meet the needs of the families. And I think Dr. Bergman and also Director Kent made a point of the fact that you can't really coordinate unless you have a plan. So it seems to me that every child with special needs, regardless of what that special need is, ought to have a multidisciplinary, multi-agency plan. And if the child is one whose primary needs are served by a regional center, then they should have the responsibility for creating that plan, but they need to engage CCS, education, mental health, and others in that. If a child's primary concern is mental health, then that ought to be done at a mental health center. But if we could come up with an agreed upon minimal content, but also minimal process for every child with special needs, that might be a way of starting to move this forward.
Oh, thank you. That's something that we should think about. How do we go about coming up with a plan? And no, it's a very good point. Excellent. Okay. All right. Seeing no other people at the microphone, I want to again thank you all for attending, and we have a lot to think about and to work on. And again, I want to thank all the presenters here today. Really appreciate you taking the time and presenting before the Select Committee. And so with that, we have a lot of work to do, and looking forward to continue to move things forward. So with that, the Select Committee is adjourned. Thank you.